Good evening, everyone. I am Dr. Vinita Ramnani, Chairperson, Scientific Committee, Madhya Pradesh. And we are having a fourth session of our Preceptors of Future program. This is from the Jabalpur division. And luckily, Dr. Ashok Singhai is joined today. He is the president of Madhya Pradesh Ophthalmic Society. He will give the welcome address. And with this, I welcome all of you, Dr. Parvez Siddiqui and our coordinators, Dr. Shweta, the judges, Dr. Pankaj Chaudhary, and many others are going to join. So thank you all of you being with us for this Preceptors. This time we are not going to announce the Indore division results because it's halfway. So the Indore division results will be declared along with the Ujjain division. And who will be who will win this competition? The first of this competition will be invited to the physical conference at midterm Jabalpur and has to compete with the other division number one preceptors. And this way we are going to have a physical session for 6 divisions at Jabalpur on 9th of the April. So with this note, I invite Dr. Ashok Singhai sir to please give the welcome address.
Good afternoon, everyone. It's a warm welcome from my side to MPSOS Preceptive from Jabalpur. All the participants, all the best, and the judges and all, everyone having good luck and should have a very good feast of the knowledge. Thank you.
Thank you, Singhai sir. Dr. Shweta, please introduce our judges and the presenters of today's competition and give them a short rules.
Good afternoon, everyone. And today we are having Preceptors of Future for Jabalpur Divisional Ophthalmological Society. The presenters for this session are Dr. Palak Patwa, and her mentor is Dr. Navneet Saxena. Second presenter is Dr. Soumya Iyer, and her presenter is Dr. Parvez Siddiqui sir. Third presenter is Dr. Shweta Singh Jadon, and her mentor is Dr. UP Dipankar sir. And fourth presenter is Dr. Ekanksha, and her mentor is Dr. Wankhede sir. So each presenter will be given 5 minutes to present his topic that has been allotted long back, and the presentation will be judged on quality of presentation, way of presentation, relevance of content, and adherence to time. So a total of 100 marks they'll be judged from, and each for these topics will be 20 marks each. The judges are Dr. Manas Setia. He has not yet joined and will be joining soon. Dr. Amit Porwal, Dr. Himanshu Shukla, Dr. Rakesh Shakya and Dr. Praveen Khare are not joining. So in their place, Dr. Singhai sir is there, who will be judging this session. So best of luck to all the participants, and we welcome you all for this session. Thank you.
Thank you, Dr. Shweta. And I request Dr. Shweta also to please keep time and also judge them, because Dr. Shubhra Mehta, Dr. Shweta Walia, Dr. Ashok Singhai, Dr. Pankaj Chaudhary, I think they are the 4 judges they will be judging. So Dr. Shweta, please do the honors and welcome Dr. Pankaj Chaudhary. We have 4 judges for this and 4 presenters. So we will start with first presenter. She is Dr. Palak Patwa, and she will be presenting anterior segment OCT. So Dr. Palak, are you ready?
Ji, ma'am. Ma'am, is I audible?
Yes, you are visible as well as audible.
Ma'am, my screen is visible?
Yes.
Ji, ma'am.
All the best, Palak, and you can start.
Ji, ma'am. Good afternoon, respected judges on all the one present here. I am Dr. Palak Patwa. My guide is Dr. Navneet Saxena, sir, and I am presenting my seminar on anterior segment OCT. As we all know, it is a non-contact, non-invasive diagnostic technique which permits high-quality resolution cross-sectional imaging of the optical structures near infrared light. Its principle is based on low coherence interferometry. Time delay and intensity of infrared light reflected from the tissue structures against a reference beam and produce cross-sectional image of the tissue. This is the spectral domain OCT in our department. Its indications are cornea-based refractive surgeries, ocular surface disorders, cornea dystrophy and degeneration, keratoconus and ectatic disorders, keratoplasty, descent membrane detachment, glaucoma evaluation, and intrastromal foreign body. This image shows the normal anatomy of the cornea. Outermost is the hyperreflective tear film, below which is the epithelium, below which is the Bowman's membrane. This whole of the thing is the stroma, and innermost layer is descent membrane and endothelium. This is the anterior segment OCT in keratoconus and ectatic disorder, showing focal thinning and corneal asymmetry. Here, descent membrane tear is seen in which aqueous imbibition occurs and acute hydrops is present. Here, we can see that hyperreflective shadow in lower segment of the stroma, which is the demarcation line in collagen cross-linking, and intrastromal ring segments are seen. Now, corneal dystrophies, it is a Bowman dystrophy. We can see that hyperreflectivity in the Bowman layer and anterior stromal layer. Here is the granular dystrophy in which hyaline deposition is seen in the stromal layer. Here is the macular dystrophy in which glycosaminoglycan accumulation is seen in stromal layer. These are the corneal degenerations. This is the picture of pterygium showing hyperreflectivity in the epithelial layer, which is adherent to the anterior stroma and Bowman's basement membrane. This is the Charlesman nodular degeneration. Here we can see hyperreflective hyaline nodules. This is the ocular surface disorder. In this, hyperreflective thickened epithelium is present, which is with aberrant transition zone. As we can see, this is the normal corneal cornea, and this is the abnormal cornea. Now, preoperative planning in keratoplasty, we can see the depth and extent of corneal opacities and corneal pathologies, associated corneal thinning and irregularity, retrocorneal characteristics like membrane, fibrovascular pannus, anterior segment anatomy can be seen, and intraoperative guide while lamellar keratoplasty can be performed with anterior segment OCT. We can see that this is a pseudophakic bullous keratopathy showing hyporeflective cystic bullae subepithelial. We can also measure the corneal scar depth preoperatively in the corneal opacity patients. We can see descent graft position and retrocorneal characteristic like this is retrocorneal membrane visible. Now, anterior segment OCT in infective keratitis can be helpful as we can see hyperreflective infiltrate with retrocorneal pathologies and different layer loss in the corneal stroma. Now, this is the normal anatomy of anterior segment angle. We can see that this is the descent membrane, this is the Swalbase line, and this is the angle recess. This is the iris, and this is the iris body. Here is the anterior chamber angle. We can also measure it in the degrees. This is the post-tuberculectomy patient showing sclerotomy and root of the aqueous outflow. This is the suprascleral hypocystic fluid space. This is the conjunctival bleb showing subconjunctival fluid space. And this is the iridectomy shown on the anterior segment OCT. These are the large lens vault and pupillary block mechanism is seen with narrow angle. Here, adherent leukoma is seen with slit open angle. In refractive surgery, we can assess the visualization of LASIK flap as in this picture. This is the picture of descent membrane detachment in the anterior segment OCT. And we can also see the intrastromal foreign body. Like in this picture, we can measure the depth of the intrastromal foreign body, and it also helps us to remove the intrastromal foreign body, and we can localize that it is present in which layer and helps in its management. Thank you.
Good.
Thank you, Palak, for excellent presentation. It was indeed a really very good diagrammatic presentation of each and every pathology. What is the role of anterior segment OCT in limbal dermoid? You could have also
Yes, ma'am. Ma'am, in limbal dermoid, it is a type of choriostoma. So, like in ocular surface squamous neoplasia, we can also see the extent of limbal dermoid, how much it is extending in the cornea, how deep is it, and we can help in diagnosis and as well as management and post-operative care in anterior segment OCT. We can monitor the patient post-operatively with the help of anterior segment OCT also.
Thank you, Palak. Now the judges can ask the question, and I welcome Dr. Manav. He has also joined.
Very good evening, all. Dr. Palak, nice presentation. Also, congratulations to your mentor, Dr. Navneet. Just one question: what is the role of epithelial mapping?
Sir, epithelial mapping, we can also we can do epithelial mapping with the help of anterior segment OCT in keratoconus patient. As we can see, there is focal thinning, so it should guide regarding the keratoconus patient. And we can also do pachymetry and corneal thickness assessment with the help of anterior segment OCT in keratoconus patients and ectatic disorders.
No, you're not up to the point. Like, why do we need to do epithelial mapping if at all you know about it?
Sir, we in
like keratoconus
sir,
start. Where will the keratoconus start?
Sir, in inferior quadrant of the cornea, inferior segment. So we can measure the IS and IT segment epithelial mapping, and with the help of the diagnostic criteria, we can assess.
No, it will start from the posterior surface. It will start at the posterior floor, where you will pick it up on topography, right? But on the epithelial mapping, you will see certain changes in the epithelium also. That's how epithelial mapping plays a very vital role in early detection, which is the new add-on to the anterior segment OCT objectives, to pick up early cases and not to go in for such cases with refractive solutions. Otherwise, very nice presentation. Role of anterior segment OCT in Descemet's detachment, which is a very complication of any cataract surgery.
जी sir, sir, if we have machinery intraoperative OCT, then we can assess intraoperatively that there is a Descemet membrane detachment occur, and we can seal that with an air bubble, and we should postpone the surgery. Also, we can observe if there is corneal edema in post cataract surgery patient. Then, with the help of anterior segment OCT, we can find out that there was Descemet membrane detachment, and that's how we should further manage it.
Yeah. Thank you. Very nicely.
Hello, Palak. Good presentation. What is the role of ASOCT in cataract surgery in relation to posterior polar cataracts?
Ma'am, in posterior polar cataract, ma'am, exact role, I don't know, ma'am. Sorry, ma'am.
Actually, you can find out about the posterior capsular dehiscence in case of posterior polar cataracts, both pre-operatively as well as with intraoperative OCT. It has been found to have high sensitivity and specificity for predicting the posterior capsular dehiscence in case of posterior polar cataracts.
Okay, ma'am. Thank you, ma'am.
Dr. Palak, it's a good presentation.
Thank you, sir.
I would like to ask you whether the pigmented KPs can be located or not on the posterior surface.
Yes, sir. It can be seen in endothelium on posterior surface in anterior segment OCT as hyper reflective dots on the endothelium.
Thank you.
Dr. Pankaj?
Is there any difference between the anterior segment OCT and the OCT attachment with the posterior segment OCT? Or the findings are same in both? Hello?
Sir, exact answer. Sorry, sir. I don't know the exact answer regarding this.
Okay.
You can give answer, Dr. Pankaj.
Actually, angle can be seen in both, but anterior segment OCT, specifically anterior segment OCT, is better than the attachment in the posterior segment OCT for the better visualization, especially for the angles. When you do the angles, then anterior segment OCT machine is better.
Yes, sir. Thank you, sir.
We can simultaneously monitor the both sides angles, like the nasal and the temporal, in one go in ASOCT machine. So in that, when you are calculating the lens vault, as you mentioned, in cases of angle closure, So in that you can calculate the vault, that which is not possible with an attachment with the posterior segment.
जी मैम.
I welcome Dr. Richa Sharma. She has joined. Any other question, judges?
Dr. Palak, which angle structure is used as a reference point for assessing the depth of the angle and all the other parameters of the angle? Which is used, which structure you have to identify first and use it as a reference point?
Ma'am, Schwalbe's line.
It is actually the scleral spur. It's actually the scleral spur that you have to identify first and then use it as a reference point.
Okay, ma'am.
Good presentation, Dr. Palak. Thank you.
Thank you, ma'am.
Thank you, Dr. Palak. With this, we come to the second presenter, Dr. Soumya Iyer, and the mentor is Dr. Siddiqui, who has joined, and she will be presenting ocular finding of HIV.
Very good afternoon to all the respected judges present here. I am Dr. Soumya Iyer, and I'm going to present my topic, ocular findings of human immunodeficiency virus, under the guidance of my professor, Dr. Parvez Ahmed Siddiqui, sir. The human immunodeficiency virus is a malady for all of us globally. The immunological hallmark is a selective loss of CD4 plus T cells. With a decrease in the CD4 plus T cell count to less than 200 cells per microliter, it leads to a host of opportunistic infections and unusual neoplasm. With the advent of modern era incorporating highly active antiretroviral therapy and newer diagnostic modalities like PCR for intraocular fluids, the morbidity has gone down considerably. The ocular findings of HIV can be described under the following headings, namely ocular adnexal, anterior segment, posterior segment, neurophthalmic, neoplasm, drug-induced or iatrogenic, and immune recovery uveitis. A definite pattern of ocular complication is associated with various levels of CD4 counts, like less than 500 cells per mm cube can lead to lymphoma, Kaposi sarcoma. Less than 250 can lead to toxoplasmosis, retinal microvasculopathy, and less than 100 can lead to keratoconjunctivitis sicca and CMV retinitis. The ocular adnexal findings are bacillary angiomatosis, the causative is Bartonella, and occurs when the CD4 count is less than 200 cells per microliter. Molluscum contagiosum, causative is large DNA pox virus, and there is profound dysfunction of T cell lymphocyte mediated immune response. It is characterized by pink or pearly white wart-like umbilicated lesion and managed by HART, lesion excision, and cryotherapy. In anterior segment manifestation, there is herpes zoster ophthalmicus. Incidence is 10 to 20%, and the risk is 6.6 times higher. There is vesiculobilous rash along the distribution of the ophthalmic division of the trigeminal nerve with the necrotic skin lesion. There is pseudodendriform keratitis, stromal keratitis, uveitis, retinitis, and even encephalitis. Bacterial keratitis, the causative are Staph aureus, Staph epidermidis, Pseudomonas aeruginosa, Klebsiella, and Streptococcus, and it is characterized by bilateral corneal ulceration, which are polymicrobial and with a higher risk of perforation. Microsporidial keratitis with bilateral superficial punctate keratitis and wide intraepithelial infiltrates. This viral keratitis caused by herpes simplex virus with reduced corneal sensation, corneal scarring, iritis, and increased intraocular pressure. The posterior segment manifestation includes cytomegalovirus retinitis. The incidence is 15 to 40% of ocular infections, the most common ophthalmic manifestation of opportunistic co-infection. There are three presentations, classical or fulminant. At low CD4 count, there is classical Pisa pie appearance with large intraretinal hemorrhages against the background of whitened edematous or typically necrotic retina, which is typically in the posterior pole. The granular or the indolent form, which is found in the retinal periphery, in which there is no or very little retinal edema or hemorrhage. And there is perivascular form, which is a form of frosted branch uveitis. Treatment is via HART, anti-CMV, in which high-dose induction therapy with either intravenous ganciclovir or fosarnet is given for 2 weeks, followed by low-dose maintenance therapy of fosarnet or oral valganciclovir. And there is intravitreal ganciclovir or fosarnet. Acute retinal necrosis caused by HSV1, HSV2, and varicella zoster. There is peripheral confluent lesions spreading circumferentially. There is necrotizing herpetic retinitis with well-demarcated multifocal coalescing full-thickness retinal necrosis. In progressive outer retinal necrosis caused by varicella zoster virus, there is outer retinal whitening, also called as the cracked mud appearance. There is posterior full-thickness retinal lesions. Ocular toxoplasmosis, which is here seen as headlight and fog appearance. There's focal, multifocal, or diffuse necrotizing retinitis with indistinct borders. Ocular tuberculosis, which is seen as asymptomatic choroidal tubercles, subretinal abscess, and conjunctival tuberculosis. Disseminated form gives a clue to the miliary form of the TB. Ocular syphilis presented as anti-uveitis, significant vitritis, diffuse retinitis, and plecoid chorioretinitis with pan-uveitis and optic neuropathy. Neuro-ophthalmic manifestation characterized by optic atrophy, disc edema, optic neuritis, cranial nerve palsies, retrobulbar neuritis, and cortical blindness. In neoplasms, there is Kaposi's sarcoma, which is a highly vascular mesenchymal tumor characterized by the presence of multiple purple to red nodules on the skin and mucous membrane, and it is caused by human herpes virus or Kaposi's sarcoma herpes virus when CD4 count is less than 150. OSSN or ocular surface squamous neoplasia, the incidence is increased and is a presenting sign in now in 2/3 of the patients. It presents a pigmented or non-pigmented papillary lesion with intralesional blood vessel or the feeder's vessel with raised plaque. In HIV infected, it is larger and more aggressive. There's ocular red blood cell lymphoma or intraocular lymphoma. These are B-cell non-Hodgkin lymphoma seen in HIV or AIDS patient, and these are seen as erythematous lesions affecting the orbit, lacrimal gland, conjunctiva, and the eyelids. Drug-induced uveitis or iatrogenic, there's careful monitoring is advocated during the treatment of HART due to the potential for harmful drug interactions and age-related deterioration in the renal and hepatic function, affecting the drug clearance. Most commonly implicated are cidofovir and rifabutin, and these respond well to topical corticosteroids and cycloplegics. Immune recovery uveitis, it is a part of the immune reconstitution inflammatory syndromes. These reactions can worsen the clinical manifestation of the opportunistic infections, which are the paradoxical reaction, or develop new manifestations shortly after the initiation of HART, which are the unmasking syndromes. Now, for management of a patient with suspected ocular TB, there are do's and don'ts.
Time up.
Okay, thank you, ma'am.
You can continue, but the judges will note down the time.
Management was not her part also, so we can consider that she has finished in time because it was only the ocular presentation, but just for the sake of completion, please continue, Dr. Soumya.
Okay, ma'am. For those, we have to monitor that in younger patients with herpes zoster ophthalmicus or typical ocular manifestation, in a corneal perforation in a patient with herpes zoster ophthalmicus infection, molluscum contagiosum lesion in a young patient, and atypical presentation of any ocular disease. And what we don't have to overlook is we shouldn't overlook HIV, early HIV microangiopathy. We should treat immune recovery uveitis with aggressive steroid therapy for CMV retinopathy, and we have to also monitor CMV retinopathy reactivation. And we should not consider all CMV retinopathy to be HIV related. We have to rule out other causes of immunosuppression like organ transplantation, diabetes, and other causes of steroid oral therapy. And we shouldn't overlook the patient's CD4 counts and then give the HIV treatment regimen. Thank you.
Thank you, Dr. Soumya, for wonderful compilation of all the findings of HIV patients, and they are very important, very well presented and documented HIV-related eye complications. Thank you so much, Dr. Soumya. Now, the judges can ask the questions.
Dr. Soumya, nice presentation. Also to your mentor, Dr. Professor Siddiqui. How will you first differentiate between ARN and PORN? If you have a case of multiple hemorrhages at the posterior pole, suspected of being HIV positive, what are the differentiating features between acute retinal retinosclerosis and posterior outer retinal necrosis?
Acute retinal necrosis is more in the posterior pole, whereas progressive outer retinal necrosis is more in the periphery. And progressive outer retinal necrosis causes white, as it is said, it is causes white mud appearance, cracked mud appearance, and it is more in the periphery. While as acute retinal necrosis is seen more in the posterior pole, and it is seen with more number of hemorrhages and exudation.
No, you got confused. You just said what was of PORN. You said in ARN, and ARN is more peripheral in nature. PORN most. So P stands for posterior pole. So that's where you will find these lesions, characteristically of multiple hemorrhages, dot and blot hemorrhages, and even few other typical lesions. But that is mostly constricted to the posterior pole. ARN will always be in the periphery. Again, another differentiating feature would be vitritis, which will be more in ARN and not in PORN.
Yes, sir.
What is the most common ocular presentation of HIV in posterior segment?
Sir, it is CMV retinitis.
Plethora that you just said between CMV retinitis, ARN, PORN, and NHI, other related features.
So the most common is cytomegalovirus retinitis. It is seen in 15 to 40% of co-infection cases.
No, doctor, again. It's tuberculous choroidal granulomas.
Okay.
You need to get back. Anyways, it was actually a Herculean task to attempt on something like that in 5 minutes. You need to cover up a lot. My best wishes.
Thank you.
Hello, Soumya. That was a nice presentation, a very vast presentation. I think it is almost befitting a 1 hour lecture that you have covered in 5 minutes. Nice presentation. I have one question for you. Can you tell me what is zoster sign herpete? Zoster sign herpete. Sign is a Latin word.
Sign means without. Yes, ma'am.
What is zoster sign herpete?
Sorry, ma'am. I'm not aware of it. I'll read about it.
It is basically, in this case, the herpetic rash does not appear. The typical vesicobullous rash does not appear, but there are the typical neurological symptoms like the typical neuralgia that accompanies the rash, and with the typical dermatomal distribution that is indicative of the reactivation of the varicella zoster virus, but there is no rash.
Okay.
That is the meaning of zoster sign.
Zoster sign herpete. Yes,
okay, thank you.
thank you.
How will you differentiate between HIV-induced uveitis and the immune recovery uveitis?
Ma'am, HIV for immune recovery uveitis, we have to look for CD4 counts. Like after giving the treatment, we have to monitor for the sign and symptoms, and then we have to look for CD4 counts. That if CD4 counts raise, and then even then the symptoms and the signs do not disappear, then we can think about immune recovery uveitis.
HIV-induced uveitis is mostly affecting the anterior segment more. In this case, you will have high viral loads and low CD4 count. While in immune recovery uveitis, the CD4 counts will be high and the viral load will be low.
Yes, ma'am.
Thank you, Soumya.
Thank you.
Thank you. Thank you.
Anyone wants to ask more questions? Otherwise, we can move to next presenter. Okay, sir. So thank you, Soumya. Now we go to third presenter, Dr. Shweta Singh, and she will be presenting on keratoprosthesis. So welcome, Dr. Shweta, and all the best.
Ma'am, am I visible?
No. Yes, you are joining. Perfect. You have.
Ma'am, is my screen visible?
Yes, beta, you can go ahead. And you are audible also.
A very good afternoon to respected judges. I'm Dr. Shweta Singh Jadon, and I'm going to present this presentation on the topic keratoprosthesis under the guidance of my professor, Dr. UP Dipankar sir. Keratoprosthesis implantation is a procedure that involves full thickness removal of the cornea and replacement by an artificial cornea. The design of a keratoprosthesis can be likened to some extent to that of an intraocular lens consisting of an optic and a haptic. Depending upon the keratoprosthesis haptic material, it can be divided into bio-integrated, biocompatible, and biological. In bio-integrated, there is PMA skirt, which is found in type 1 and 2 keratoprosthesis. In biocompatible, there is a Dacron skirt, which is found in Pintucci Capro. In biological, there is tooth or bone, which is found in osteodonto and osteokeratoprosthesis. Now, supporting cover tissue is bandage contact lens in type 1 Capro, skin in type 2 Capro, and buccal mucosa in osteodonto, and Pintucci Capro. Now, indications for type 1 keratoprosthesis are multiple failed grafts, aniridia, herpetic keratitis, silicone oil-filled eyes, immune-related conditions like Stevens-Johnson syndrome. Now, indications for type 2 keratoprosthesis are Stevens-Johnson, ocular mucous membrane pemphigoid, severe chemical injuries, and severely keratinized surface. Exclusion criteria includes nil perception of light, advanced glaucoma, poor compliance to follow, and dense amblyopia. Preoperative evaluation includes a detailed history as well as detailed ophthalmological examination, which includes visual acuity, T-scan, axial measurement, intraocular pressure, ultrasound biomicroscopy, Schimmer's test, and patients enlisted for modified osteodontokeratoprosthesis have to undergo dental and oral evaluation, spiral CT to evaluate the canines, and pre-anesthetic checkup also. Now, Boston type 1 keratoprosthesis for pseudophakic or aphakic adult patient, 8.5 millimeters backplate is used. For pediatric, 7 millimeters backplate is used. The minimum donor graft size should be 8.5 millimeters and is usually oversized by 0.5 millimeters. The optic and backplate is kept and locked with the titanium ring. The assembled K-Pro is then sutured using 16 interrupted 90 nylon suture. A BCL is placed on the K-Pro. Now, Boston type 2 keratoprosthesis, it is largely similar to the Boston. There is no separate titanium ring, and in the recipient, the entire conjunctival mucosa is removed from lid margin to lid margin. Sphincterotomy is done to keep the pupil mid-dilated. Following the K-Pro suturing, PPV is performed along with Ahmed glaucoma valve implantation in all the eyes. The lid margins are excised and sutured in 2 layers. Now, post-operative regime includes topical antibiotics, topical steroids, topical lubricants, and BCL to be changed once in 3 months for type 1 K-Pro, and lid sutures are removed on day 10 for type 2 K-Pro, and follow-up is done every 3 months. Now, modified osteodontokeratoprosthesis, it consists of replacing the ocular surface with a full-thickness oral mucosa graft that provides sustenance to a PMMA optical cylinder embedded and supported by the patient's tooth and alveolar bone. Now, osteokeratoprosthesis, this procedure is very similar to the modified osteodontokeratoprosthesis. The bone is harvested instead of the tooth from the tibia, and the same is fashioned into an osteolamina in which the optical cylinder is fixed. Now, the complications are sterile melts, glaucoma, and retroprosthetic membrane. Sterile melts have been noted to occur in up to 26% of the eyes. In mild cases, we go for cyanoacrylate glue. In moderate, annular lamellar graft, and in severe cases, we have to replace the K-Pro with a new one. Retroprosthetic membrane has been reported as the most common complication. Glaucoma continues to be the most important comorbid factor, and endophthalmitis is found in approximately 15% of type 1 K-Pro, 10% of eyes with modified osteodonto K-Pro, as well as the Boston type 2 K-Pro. Fungal and bacterial etiology are found in similar number of cases. These are the images of some complications. To conclude, I would like to say that KP surgery is a boon to the patients of corneal blindness not amenable to conventional treatment. Careful and continued follow-up is needed. It is continuously evolving with newer generation materials. However, the cost of surgery remains on the expensive side. Thank you.
Thank you, Dr. Shweta, for such a wonderful presentation of a very less spoken topic of keratoprosthesis. And you have narrated so well that it's very clear that whatever you wanted to tell us, it was perfectly said and very well presented. Thank you so much, Dr. Shweta. Now, judges can ask the question, please.
Anyone?
Hello, Shweta. What will be the keratoprosthesis of choice in a dry, highly keratinized eye?
Ma'am, we can go for type 1 Boston type 1 keratoprosthesis, which is the most commonly used keratoprosthesis. Its indication is in severely keratinized dry eye.
I'm sorry, you are wrong, Shweta. Type 1 is used in wet eyes. Boston type 1, that is used in wet eyes. In the case of dry, severely keratinized eyes, you don't use Boston type 1. You use either Boston type 2 or more preferred keratoprosthesis is the modified osteodontokeratoprosthesis. That is the keratoprosthesis of choice in dry keratinized eyes. If the tear film is adequate or if the eye is moist or wet, we prefer to use the type 1 keratoprosthesis.
Anyone else?
No.
Dr. Shweta, very nice presentation. The only right person to talk about keratoprosthesis in our pan-India would be Dr. Muscati. I mean, we hardly have any experiences with these keratoprosthesis. But what I understand what I know about the keratoprosthesis part is the CMP, as you said, Dr. Shweta, was the Chavan Muscati Pintucci implant, which was fabricated and designed by his father, Dr. Muscati's father. And he has been presenting a large number of papers, including the one on OKP, which is the osteokeratosis. So that's where far we are being exposed to even these keratoprocesses, but it plays a very vital role in these significantly dry eyes. Very well summarized.
Even Shankar Netralaya people, they are doing so many keratoprostheses, and they are holding in one conference for this also. And I have seen Dr. Geeta Iyer's cases, very well presented and done cases for such a terrific eyes, especially in chemical burns, like have a bilateral burns of the face and then horrible chemical injuries, and probably they have a vision. She has shown up to 6669 vision with keratoprosthesis. So it is not like that they may not have a vision because the posterior segment is good. It's only the ocular surface which is not good. So in place of keratoplasty, they are going for a keratoprosthesis. Thank you, Dr. Shweta, for a very wonderful presentation, and thanks to your mentor, Dr. Dipankar. Now we move on to fourth presentation by Dr. Akansha Ekka, and she will be presenting on trifocal IOLs. Dr. Akansha, you
yes,
can join.
Ma'am, is my screen visible?
Beta, are you presenting from mobile? Your screen is so small.
No, ma'am, it's an iPad.
Okay, iPad. Because the view which we are seeing is only 1/4 of the screen. Your screen is totally visible, but it is smaller. Otherwise, you can go ahead, beta, no problem.
Yes. Good afternoon, everyone. I'm Dr. Akansha Ekka, presenting on the topic trifocal intraocular lenses under the mentorship of Dr. Padmini Varkade, ma'am. Introduction. Trifocal intraocular lenses are the latest generation of multifocal IOLs. As the name suggests, trifocal IOLs are designed to provide near, intermediate, and distant visual performances. Trifocal IOLs are developed in order to achieve a useful third focus for intermediate distance vision. It allows a person to switch effortlessly between all the three distances: near, reading distance, long distance, and in-between distances. Vision is clear at all those points, something that the previous multifocal IOLs couldn't achieve. History. In 2010, the company Physiol released the first ever designed trifocal intraocular lenses for the replacement of crystalline lenses during cataract surgery. This new generation multifocal IOL is based on the proprietary diffractive profile named Fine Vision. Fine stands for the acronym far, intermediate, and near. This IOL has been implanted in thousands of eyes and produces satisfying and predictable visual performances by allowing the patient to become spectacle-free for near distance and intermediate vision. Previous multifocal IOLs were bifocal and did not satisfactory intermediate vision. Now, the structure of trifocal IOLs, it has concentric rings, which were also same as in bifocal lenses, but here it provides an intermediate foci for the intermediate vision, which is at around 60 to 80 centimeters. It is based on the principle of diffraction. Diffraction occurs when the light passes a sharp edge obstruction, for instance, the concentric sawtooth pattern on the surface of a multifocal IOL and propagates forward as waves. The speed of light is faster in the aqueous than in the lens material, so the thicker side of each sawtooth delays the light by approximately half a wavelength. When the light wave exits the posterior lens surface, they produce a band of constructive and destructive interferences, bands where the light reinforces itself and the bands where the light negates itself. Typically, the bifocal IOLs use the base diffractive power of the IOLs for far vision and diffracted light to create a near focus. However, diffraction must also bend some light in diminishing amount towards even closer foci. The light is lost to useful vision and produces glare and halos. The second diffractive order has a version that is double the amount of the first order. The trifocal IOLs use the light diffracted to both an intermediate and a near focus. They are designed so that the otherwise wasted light from the intermediate focal point, second diffractive order, strengthens the near focal point. The prerequisites for implanting a trifocal IOL is immersion A-scan, standardized manual or autokeratometry, standardized formula calculators, good phaco techniques, predictable refractive outcome, and attention to corneal astigmatism. Now, the advantages of trifocals are the current standards of cataract outcomes are not only limited to vision restoration but also its enhancement. Hence, trifocal IOLs help to achieve this to an extent. Improved mid-distance vision, allowing the patient at ease when performing activities that require mid-distance vision like working on a computer or focus on objects located at 60 or 80 centimeters. It provides spectacle independence as the trifocals provide better quality vision for far, intermediate, and near distances, providing minimal or no requirement of spectacles after the surgery, providing greater patient satisfaction. Great for people with active lifestyle as they do not require spectacles, which is a hassle during athletic activities. The defocus curve, which has become the gold standard metric for assessing the visual performance at different distances. The trifocals have a stable defocus curve for the intermediate distance and near vision. As the chart suggests that the trifocal IOLs marked in the dark brown color is showing a stable curve for the near, intermediate, and distance vision, whereas the monofocal curve only has defocus curve for the distance vision, whereas bifocal curve has a dip in the intermediate vision. Now, the disadvantages, it has reduced light intensity. The light which enters the eye is reduced, thus the greatest optical disadvantage in the multifocal IOLs. In ideal situation, not all the light entering the eye reaches the retina in focus for either far, intermediate, and distance vision. Reduced contrast sensitivity is there, so the decreased intensity of light is being focused, hence the patient requires bright light for proper visual functionings. Halos and glares may occur, so it is not suitable for people who require night driving. Off-axis aberration, decentered IOLs create more problems in trifocals as
Time up. You can continue, judges will note down.
Yes, ma'am. To conventional IOLs, hence require excellent centration. Bilateral surgery is required for better visual performance and requires visual cortical neural adaptation. Hence, the patient needs to be counseled for the same. Now, for whom is the use of trifocal intraocular lenses indicated? Patients who have an active lifestyle and do not want the hassle for wearing spectacles, want a good range of vision across all distances, and can compromise with the dysphotopsia, that is the halos and the glares. Thank you.
Thank you, Dr. Akansha, for presentation. Probably you have joined with your iPad, and rather than joining the PPT, you have just joined through the iPad. So we were able to see your whole iPad. Anyway, nice presentation, Dr. Akansha. Now the judges can ask the question which is being commonly used nowadays, trifocal IOLs.
Dr. Akansha, very nice presentation. Also, congratulations to your mentor, Dr. P. Warkede. Number one question, the patient has got an IOL implanted, which is trifocal in nature. If he comes to your OPD, how are you going to assess his visual acuity? See, we talk about focal distance between near, intermediate, and distance, right? So
yes,
that's what is the whole objective, is to make patient read very good with very good acuity at these three particular points of focusing, right? Now, if the patient has a trifocal IOL in his eye and he comes to your OPD, how are you going to assess the visual acuity?
So for distance vision, we can use the standard Snellen's chart. For the similarly for the near vision, we can use the near vision charts. And for the distance vision, we can place the near vision chart at a more further distance.
No, that's not the case. Actually, we are not even very well prepared to assess these patients in our day-to-day OPD. Even if he has a very good IOL implanted in his eye, we will not be able to assess. You have to assess them at 3 levels. As you rightly said, for distance, it has to be a Snellen's acuity visual chart. You have to also assess them on the intermediate level, which is about 60 centimeters. And that has to be a Sloan's chart. That chart is called the Sloan's chart. And for near, you have to use the Landau-C test to assess the near visual, so that whether he's really able to read those, what you are implanted. And what else are you going to measure and try to find out whether the lens that you've implanted is working nicely? What are the other parameters that these lenses should be measured on?
So the centration of the lens should be exactly.
That's exact. Good. What else? Anything to ascertain a particular value of contrast, glare, halos? How do we define that?
I'm sorry, sir, I don't know.
You need to assess the contrast acuity also.
Okay.
So you actually should be using ETDRS charts, not the regular charts that we are having in our OPD, which is 90% of the times Snellen's. So we are not even equipped. The lenses have got the benchmark has gone up, but not our way of assessing them in the OPD. Most of us are still using Snellen's visual acuity chart.
Yes, sir.
So even that needs to be upgraded and brought to a particular level. That's what I wanted to convey. Yeah, otherwise, very nice presentation, Doctor.
Okay.
Dr. Ekansu.
Hello, Akanksha. Why do halos occur when you implant a multifocal or a trifocal IOL? What is the mechanism behind the formation of halos?
Ma'am, in this lenses, the principle that it uses is diffraction. So the light which are diffracted, they meet at the 3 distances, that is the near, intermediate, and the distance vision, and the other waves of other part of the light which is left, which is not focused at these 3 distances, create halos and glare.
Actually, the image at each point of focus is overlaid by the secondary images that are formed at the other focal points. So these additional images, they cause the ghost images or the halos. What is the effect of pupil size on halos?
Either the pupils, the halos will increase.
Do the halos increase or decrease with pupil size? Is there any relevance of that?
Yes, ma'am. The smaller the size of the pupil, the more halos the patient will see.
Actually, no, larger is the pupil size, more will be the halos. That is why halos are more prominent in dim light conditions when the pupils are, larger than normal.
Focusing, yes. It's good presentation.
What is the, how are EDOF lenses better than trifocals as far as halos are concerned? How do they eliminate or decrease the halos?
Ma'am, in EDOF lenses, there are no single foci for different distance of vision. It is an elongated foci, so there are no separation in the different focus. Hence, there is no cases of halo or glare.
Okay, yes, okay. There is a single elongated point of focus. You are right. There are no multiple focal points, and so theoretically, halos should be eliminated.
Yes.
Thank you, Akanksha.
Good presentation.
Thank you, all the 4 presenters. They will very well presented from the Jabalpur division. And Dr. Pankaj, can you say something?
It was a nice presentation. It was a very nice initiation taken by you because we are taking all the seminars every time, but by this presentation now they are motivated much more because it is judged by the judges, so they are preparing it much well. So I'm happy to see this event going on because this has motivated the PG like anything. When the physical will also occur in midterm, then they'll be benefited by this, that yes, they should take all the seminars in this way and seriously. So it was credit goes to you and all the judges. Special to mention Dr. Shubhra and Manav present today, Dr. Shweta, Aditi, and all that. They are so actively motivated and ask the relevant questions to make them feel that yes, we have to make it much better next time. So this will going to improve next year again. So it was a good presentation by Jabalpur division, and all the divisions are doing well.
Thank you, Dr. Pankaj, and I would like to thank you also doing a wonderful job of compiling the results of all the judges. Thank you so much. Dr. Navneet has joined, so I will ask Dr. Navneet to say a few words.
Yes. Good afternoon, everyone. Good afternoon, judges. Good afternoon, Manav, Pankaj, Shubhra, Shweta, everyone. Actually, it was a good initiative. Hello, Shubhra, how are you?
I'm fine, sir.
Actually, yes, it was a good initiative taken by Vinita. Wonderful. So that our postgraduate really they exposed to the different people, exposed to the good dais and the podium, so they can have a good learning curve. So they can speak and they can understand. They can answer their questions very well independently without the help of any mentor. So that is very good, Vinita. It's really good of this is Preceptors of Future, wonderful program, and all the best and good luck. Good going. Very good, Vinita. Very good.
Thank you so much,
Thank
sir.
you.
All of you are there for this Preceptors of Future. We are going to continue. But I'm so surprised to see all those PGs we have been seeing from 4 weeks, and more than 30 presenters are maybe more numbers, but they are presenting so well. They are presenting like consultants. They doesn't look like they are PGs. So they are very well mentored by all of you, and the excellent presentation. And what I'm seeing that day by day, their presentation is improving.
Exactly.
The next division it is doing even better. So thank you all teachers of medical college. Thank you so much. Dr. Parvez is here. I would like to hear a few words from Dr. Parvez also.
Thank you, Dr. Vinita. I think they are doing quite well. And they are trying their level best, I suppose. And with each topic which are being presented to them, they are learning more and more. Our motive is to see that they become acknowledged and adrift with the ongoing process of ophthalmological science. And it's a very good initiative on your part, I suppose. They will learn more from it. And what I can say, my regards to you, all of the judges, and especially to you also, who has taken a bright initiative in starting this particular forum. Thank you, Dr. Vinita, for incorporating and including Jabalpur also.
Thank you so much, sir. In spite of your travel, you have joined. So that's very good of you, sir. Thank you so much for being with us from past 1 hour. And Dr. Richard Sharma thank you, sir. Dr. Richard Sharma has also joined from the beginning. So I would like to hear a few words from Dr. Richard Sharma also. Hello.
Hello, I am audible, ma'am?
Yes,
ma'am. First of all, I must congratulate you for this new beginning to include PGs in all the discussions. This is very helpful for everyone, which we missed in our PG days, and best wishes for you all. And today's presentation was good from the Department of Ophthalmology, and all the 4 presentations were very good. So I must congratulate all the presenters and their mentors. Thank you very much, ma'am. Please continue this.
Thank you. Thank you so much. You have all joined, and it was really good from Jabalpur presentation. The next week we are going to have presentation from Priva division. So we are going alphabetical. So Pankaj, be prepared. So that's really good that after Rewa, we will take Indore and Ujjain combined, and then the final round will be at Jabalpur. That will be physical in the midterm MP state. So judges, be all ready, and the winner of each division will compete in that zonal competition. Thank you so much, all of you. With this, I would like to thank Ajanta Pharma and Mr. Sanjay and Sapna for giving such a wonderful platform. Though the COVID has joined us through this Zoom platform, and we are continuing this. And nowadays, I think it is the better platform for a discussion, because we can connect to anybody sitting anywhere. So no hassle of travel. So thank you so much.
Thank you, ma'am. Thank you, ma'am. Thanks a lot.
Thank you, sir. Thank you.
Okay, bye.
Thank you, all of you.
Bye.
Thank you, all of you.
It was excellent.
Thank you, all of you.
Thank you, everyone.
Thank you, sir.
Thank you, sir.
Thank you, ma'am.
Thank you, sir. With
Nice to
this,
see
we
you,
leave.
ma'am.
Thank you so much.
Thank you.